Yeah.
Right. Again, this is a video. Again, imagine that this patient is kind of, trying to look right and left or whatever, or up and down. It's not moving much. So, how describe, summarize your findings. What can you say?
Okay. So it's a video for the external appearance of both eyes of a patient. The most prominent sign in the video is bilateral upper and lower lid retraction with scleral show. A periorbital bit of swelling in the superior periorbital tissue. There is a kind of congestion at the sites of insertion of the rectus muscles, horizontal rectus muscles in both eyes. The cornea looks clear, the pupils are equal in size, and the patient looks shaky.
And again, if they're moving their eyes, you've mentioned that there is restriction. Let's say there is restriction. Yeah.
Yeah.
Because it's the orbit station. Yeah. So it's kind of, they're trying to. Anyway, fine. Okay.
Yeah.
Anything else? Not sure. Fine. Okay. I think that's enough. What's your sort of differential diagnosis? What are you thinking?
So by far the most common cause of bilateral this could be bilateral proptosis. Looks to be left eye more than right eye. By far the most common cause for bilateral proptosis is thyroid eye disease. However,
what else? Yeah. So I'll go into that. So what else would you like to do for this patient clinically?
Clinically, I'll start by taking the best corrected visual acuity if we skip the history. So we just go straight away to examination and start by best corrected visual acuity. I'll check the visual function, color vision, pupil reaction to light. Do confrontation visual field test for this patient. I would do ocular motility versions, seductions, and conversions. Check for the lid signs of thyroid eye disease, like the Dalrymple sign and the lid lag on down gaze. I would check for diplopia.
Yeah, fine. That's in the symptoms. The most important thing in this case.
The most important thing in this case, two things, which is the vision and the corneal exposure.
Fine. I'm saying clinically, what test would you like to measure in this patient?
You mentioned thermometer.
Yes, proptosis. Yes. You definitely need to mention that.
Proptosis.
Because if you forget it, they will always keep sort of, anything else, anything else, just waste your time. So, fine. Okay. How would you manage this patient?
Okay. So according to the condition of the patient, if the patient is of uncontrolled thyroid eye disease, I would refer the patient to endocrinologist for the control of thyroid eye disease. I'll advise patients to stop smoking. I'll send the patient first of all for if we skip investigations and we go straight away to treatment.
Tell me more about the investigation. So what other tests? Any other tests that you can do?
Yeah, so I'll send the patient for orthoptic assessment, for formal orthoptic assessment. I'll send the patient for CT orbit to check for enlarged extraocular muscles with sparing of the tendons.
Blood tests? Any blood tests that you can do?
And HES chart.
Yeah, blood tests.
Yeah, blood test. Yeah, blood test obviously for thyroid function test. Yeah.
Fine. Okay, and you mentioned that you refer them to the endocrine team. What would be your management in this case if the patient has lost vision in one eye? What would you do? What would you check for?
So if the patient lost vision in one eye, check for the visual function as I mentioned in the beginning, vision, color, vision, and pupil reaction to light. If there any sort of affection of the visual function, this is an emergency, so I do a medical decompression. by intravenous methylprednisolone under the cover of medics to check for the blood pressure and diabetes to make sure they are controlled.
Fine. Okay. So you've run out of time, but I think you've covered everything, which is great. I think thyroid being in the OSCE station is a bit too much. I think thyroid is obviously a huge topic. It's more for the viva. But
Yeah.
in that sort of context, again, checking for the muscles, that's why it is in that station, because it's a strab sort of thing. They might ask you what other differential of restrictive myopathies do you know of? So it's a restrictive, obviously, strabismus. Are there any other differential in restrictions?
It could be traumatic with entrapment of the muscles in the orbital walls. It
Yes.
could be muscle fibrosis.
Those sort of weird syndromes. What was it? Mobius syndrome, other sort of stuff.
Like Mobius
Fine.
syndrome, retraction syndrome.
Yeah. Okay. It might be sort of post surgery. So again, failed strabismus surgery. Repeat surgeries can cause restriction. Fine. What else would they ask? So again, you mentioned the management. They might ask about the CAS score, the clinical activity score. I think that's too much in the OSCE, but it might be just worth in your description to say that, I can't see obvious sort of, conjunctival injection. I can't see obvious sort of skin erythema, those sort of things that, just
pain with eye movement, pain at rest.
Yes, you could show them that, that you are aware of that sort of score. And depending on that, you would say the sense. You mentioned the corneal exposure, which is another thing you mentioned. And again, just very quickly say if it's an acute optic neuropathy, I'd either manage it medically if the patient is systemically fit for it, or obviously surgery to decompress the orbit, like a orbitotomy or something. I think that's more than enough for the thyroid.
Would they go into Igogo?
I don't think there is any time for it, to be honest. So those sort of scales and grading systems, they might, but I think that's more for the viva. I don't think they'll have time. As you can see, there's time has run out. So I think the OSCE is more for how to sort of actually do the test. So obviously everyone knows how to sort of check for eye muscles. You need to make sure that you know how to do them. Something that some people miss is when you check for eye muscles, you always ask the patient, just tell me if it goes double. Yeah. Because would you mind can you just mute? Yeah, so just mention to the patient that, if it goes, just follow my hand. If it goes double, just let me know. Because sometimes, people forget about that. Obviously, avoid that sort of X sort of thing. I'd go H. Yeah, that's the better thing to do it. And that's it, really. Well done. Okay.